just to get into it, so this is SM, 67-year-old male, comes in to see us in September of 2020. Comes in with his complaint was my legs look thin. Just has muscular atrophy in his bilateral lower extremities, low back pain, some claudication. He's an attorney, of course. Has a history of prostate cancer, which has been treated in remission, hypertension. Has a history of Charcot and past surgical history. Nothing really pertinent to his low back. On currently hydrocodone 5, and on examination has cavus feet. Just his S1 or gastrocs are a 2 out of 5. 5 out of 5 rest of the bilateral motors, and then 1 out of 4 reflexes and diminished sensation at S1. And you can see his parameters here. Overall, I think that he's pretty well balanced. We don't have a scoliosis at this time, but pretty degenerative levels and facet arthropathy and spondylotic. Here's he has a little bit of a coronal curve there, if you want to call it that, just degenerative adult scoliosis. Okay, and then so you can see here just some flexion extension views. I'd argue that L5S1 does have a tilt angle that is opening on flexion extension. And then just here's some MRI that came with that, just pretty significant stenosis there at L4-5, foraminal stenosis, but other levels are not centrally, some mild stenosis. And ODI is at 16. So I kind of open up to you guys. I would imagine this is not uncommon to see in your clinic. Cliff, what would you do with this patient? How would you treat them?
Start with me. I don't get the cavus foot. Is he got CMT or something else going on?
Yeah, we sent him to a neurologist, and we wanted to rule out CMT. Said he ruled it out. Said no, not CMT. Just happens to have cavus feet. So
okay. I don't even know how to unravel this.
Ruled it out. No, he ruled it out. He has a family history of it. We took off his shoes, had some cavus feet, sent him to a neurologist, tried to get an EMG. He did recommend it. He recommended against an EMG. He said, don't think this is Charcot. Very atypical presentation. No cord tethering. No. But I'll go back to the X-rays.
So, in your history, do you think this is more a back pain issue, or is this a claudication issue? What's your
to the patient? What was most important to him was just how weak his legs were. So even though he had some back pain, some heaviness in his legs when he was walking around, he was complaining that his calves were getting thinner and just felt weak.
Oof. Was there atrophy?
Yeah, atrophy.
There's definitely atrophy.
Yeah, definitely atrophy.
And what kind of neurologist did he see?
Yeah, exactly. Yeah,
honestly,
I'm not hearing spine here at all, to be honest.
Yeah.
Are you hearing spine?
I completely agree with this. There's something fundamentally wrong with the entire history. Spinal stenosis does not create bilateral cavus feet with wasting going on. So the history, you gotta go back. Right. The question is, how long has he had wasting? Is it acute or has it been there for years? When did he deck cavus feet? Does he know about cavus feet? Does he have high stepping gait? Something's fundamentally wrong with this guy. Something's not fitting in here, right?
And he's not stenotic.
So I'm grilling this guy to hell to find out what's happening. And I'm not touching this guy till I get those answers. Yeah. When did this happen? When did this pain come? What happened?
Did he relate did he notice the cavus feet? Is it something he noticed?
No, it was something
or is it something that he's had his whole life?
Yeah, we took off his shoes, took a look at his feet.
He's also complained weakness and he has atrophy. So
yeah.
I mean, you can't really rule Marie Charcot too without doing either at least an EMG, if not a muscle biopsy. Seeing a patient, I don't know how they rule that out. So I think that, to me, that would be my top differential.
Yeah, and to us, it was something's not right here. That was our first presentation. But ultimately, like a lot of patients, when you don't have enough answers for them, they disappear. And this guy definitely disappeared. We didn't get his answers. So disappears for 4 years, comes up to us now, and now his right lower extremity is buckling. That's his major complaint, and balance issues. Again, there's his past history. And then, of course, he went somewhere else. And as the revision capital of the world at FOI, we are now presented with he had an L4 S1 Lamy fusion in 2022. Now he's on Percocet 10. 5 out of 5 bilateral lower extremities. Other than that, the gastrocs that are still atrophy, but now has this kind of buckling sensation and balance issues, and bilateral Hoffmans with upper extremities with hyperreflexia.
Did his weakness, S1 weakness, did that improve at all?
Mm-mm. So it didn't improve. So we get, something's not right. We get an X-ray, and of course, what do we see? We see a spondylolisthesis there at 7.1, and then one at 3.4. Okay, so now we're thinking is this cervical myelopathy? Maybe this is a very odd presentation. So we get some flexion extension views. You can see that it's pretty significantly moving there. And so here's his MRI. We see some, don't have any axials, I think, on this patient, but I can argue some core signal changes there, autofusion there at 4.5, but so pretty significant translation there. So we ended up getting a full standing view. Here's his fusion that he had down to the pelvis. So what do you do with this? Now this patient, he's so convinced that this is his low back. I have this all the time. Someone comes in with balance issues, and now I find something in their neck, and now I have to tell them, hey, I think this is coming from your neck. How do you have that conversation?
I would MRI his whole spine, first of all, because his neck, he's got a big canal. I didn't see any myelomalacia on that MRI, I don't think.
Yeah.
Does he have a physical exam? What's his exam done now? Does he have a Hoffman? Is he myelopathic?
Yeah, bilateral Hoffman's. He has hyperreflexia in the upper extremities, and then just that weakness in the gastrocs.
So you're saying that's coming from 3-4 then?
Yeah, 3-4 definitely looks worse than.
Yeah, I mean, if he's got a Hoffman,
That's
it's
fine, yeah.
not,
Correct.
correct, right,
Correct.
right.
The
well, I
axial,
mean,
we
actually-
don't have it. The axial looks fine. Is there?
We don't. Yeah, I didn't have any.
Yeah,
axials.
well, if you're convinced, I mean, we have limited data here.
Yeah.
Hopefully we've got more, but if you're convinced this is cervical, that discussion is actually fairly easy to me to have for him. Even if you have concomitant lumbar spine issues on an MRI, I would be directing him towards a cervical. If I'm convinced he's got an ataxic gait, he's Hoffman, if he's evolving myelopathy, I would direct him immediately towards the neck.
Yeah, and it might be helpful if you had imaging at the lumbar spine just to show him. If you had a nice decompression, you can say, look, your lumbar spine looks fine. This is your neck. This is where we need to focus, and these are the symptoms of myelopathy.
Yeah.
So.
And we'll pull up those. We did get another lumbar MRI just to kind of show him, have that conversation. Look, I understand you're having this buckling. I know this weakness in your legs, but your balance issue, I think this is myelopathy. I think this is your neck. And ultimately what we did for him was a laminectomy with C2 to T2. Would anybody have done anything different on this? Do you address this purely posteriorly? Do you go anterior on a patient like this?
I think that's a nice answer. I mean, some people talk about going down another level or two down to T4, but I'm not in that camp necessarily. Posterior only for me. What do you
How
got?
do you feel about the scoliosis he's developed?
Mm-hmm. From this,
He didn't have that.
Yeah.
On his first.
Now he has this translation that's happened.
Well, fortunately, he's got those rods to prop him up.
Yeah. Actually, the surgeon who did that actually did it on purpose. He said he told the guy that he'd be back and that they would be extending up and probably a long way. But that's
Just out of curiosity, did he report any benefit whatsoever from that previous surgery?
No.
Oh, good. Okay.
Yeah, just for you guys to know, last IMAS, there was a great paper, actually came from India, looking at flexion extension MRIs, showing unbelievable stenosis as they moved through that.
Yeah.
That was fascinating. These were all myelopathic patients that the MRI static did not look that bad. And they actually was at present IMAS, I think SRS2, significant stenosis as they go back to forth. Now, I don't know if we can do it here. They had a special MRI. They were able to do that. It came from India, actually. We should be doing that stuff. Well, we see this a lot, and patients are symptomatic.
Right.
And myelopathy is a clinical diagnosis. I don't care what the damn MRI looks like.
Mhm.
We've all seen patients with severe stenosis with no myelopathy.
Right.
We've all seen that. It's a
And the
clinical
opposite.
diagnosis.
Myelopathy with fairly modest. Yeah.
The opposite is that flexion extension has a
Yeah.
mild balance, and this thing was anyway.
Yeah. Well, and what the whole point of this particular case discussion is, what levels do you do? Right. So this patient now has a scoliosis, and we're trying to avoid too much surgery. But where's the middle? Is this enough surgery for this patient? He has a grade 3 spondylolisthesis at
It is
7.1.
It is for a couple of years.
Yeah.
He would highlight his low back was incidental, I think.
Yeah. So April 2024 comes back to us, still having balance issues. bilateral lower extremity weakness, feels like he's going downhill, feels like he's like leaning forward. He feels like he's falling. Again, you know, his history. Now he's on gabapentin, and this is just setting up the classic annuity of the spine. And, you know, and we put him in a CTO brace. We're hoping this is doing something for him. So here's his MRI.
That's great.
Postoperative, great decompression at those levels. So you'd argue that, don't think this weakness still in the lower extremities is coming from that. And then so here's that repeat MRI.
Yeah, thoracic MRI, just like
What about thoracic?
Yeah, I don't know, Dr.
Yeah, he had a thoracic.
Yeah.
Yeah, that was all right.
So what we can see here is we have some severe stenosis, possibly at L3-4, now above from adjacent segment disease there at that lower level, and then at L2-3, and then they had that laminectomy at those lower levels. But so what do you do now? You know, what do you do for this patient?
Well, just to clarify, once you have that degree of myelopathy, the balance issue is a hard one to be judging
Right.
going forward. So you've got to try and correlate his worsening symptoms to what you're proposing to do.
Mhm.
So I would inject the areas junctionally, diagnostically.
Mhm.
Is he giving you a claudication story? Is he giving you anything that tells you his low back is an issue? Or is he just singing the same old song?
No, it was more of a claudication.
He was.
Yeah.
Okay. So if he starts switching over to a low back patient,
Right.
then now you're talking about extending him up.
Seems like pain is becoming more of an issue because he started off
Right.
taking some occasional
Yeah, hydrocodone.
hydrocodone, and now he's up to Percocet 10.
Right.
So, you know,
Yeah.
pain might not have, but now he's transitioned from whatever that was, whether it was a stenosis at 4-5 or whether it was myelopathy or whether it was Charcot-Marie tooth. Now he's transitioned to a mechanical back pain
Right.
problem.
It's adjacent
And
segment.
so I think your philosophy and how you manage this is going to
Yeah.
change now that pain is becoming more of the dominant issue.
Right.
He had extensive rehab. Gosh, probably 6 months at least. And his biggest complaint at this point was leg weakness, kind of back to the way he was when he first came in.
He's still not a deformity patient to me. He's a stenosis patient. So I'm not connecting it. I can tell you that. I'd go up to his junction level 1 above or 2 above?
Two
Two above. So that gets you up to 2.
You know, my concern was the progression.
Of-
Yeah, if you
of-
look at
is he
his first
comp- is he
X-ray.
decompensating coronally?
What's that?
Yeah.
I think he's
yeah,
decompensating
coronally,
coronally.
yeah.
Yeah.
I mean,
And also, if you look up in the cervical, he's starting to kind of, you know, I think you had said, Cliff, maybe go down a couple more levels on that.
I said I'd quit. I don't know that I would, but people talk about going
Right.
down to 4 if you got a spondy at 7-1.
Yeah. And I think that's and
So
Yeah.
go back the years if you don't mind. Just
yeah.
let me just see so that's what year is on the left?
This is 2024,
And it's pre-op where
2022.
When did you do the neck?
Oh, that was 2024. Yeah. That was
neck was
20
done in 2024.
Yes. that
And
was-
then so in the interim between the index operation they did elsewhere to coming back, he progressed both his lumbar curve and
And
his
his-
thoracic and his cervical.
Right.
Okay. All right. And when you fix this, you basically unroofed his lumbar stenosis as being problematic.
Correct. Yeah. Because he came back, he was having some claudicatory symptoms. We get an MRI, we see some adjacent segment disease.
And you did or did not do an injection of
I don't think, did we?
He did have an injection, I think, but I think he had 1 or 2 injections, but just really didn't want to pursue that any
Okay.
further.
Another, but you were pretty convinced of stenosis below. So,
Right.
So to me, it's either stop now or go up.
Right.
So
Right.
if you feel that you've identified his source and you think it's at 2-3 level,
I think he's showing you what happens when
Yeah.
you fuse him, right? He
Yeah.
degenerates, and you know some people just have protoplasms where you fix them and they fall apart above and they fall apart above. So
right.
I don't know if that connected to, but I certainly wouldn't stop in the upper lumbar spine.
Does anybody on the panel think the extended rods anticipating the extension of the construct to disease
Yeah.
or like
They're long enough to fit a domino.
So just sake of time. So we extend him up, you know, multi-level TLF, T10 of the pelvis, extend him up, and he's doing pretty well. He comes in with intermittent kyphosis and it's a little bit of DJK below that cervical, but then he's able to convert utilizing physical therapy. He uses walking sticks to hold himself up, and it'll transition to our next talking about this. But do you ever anticipate connecting him at some point?
Have you, did he have a bone health eval?
Yes.
This is somebody I would like to get Forteo on for a couple of years and maybe avoid what is
Was he osteoporotic?
likely.
No.
He wasn't. No, he was. I think he
I doubt it, actually.
was osteopenic, but yeah, he's not. He wasn't osteoporotic.
No.
Yeah, Mike. Yeah, to be honest with you, I meant because my thought was that with that kyphosis that he had, I wanted to overcorrect him a little bit. I probably overcorrected him maybe just to try to keep his head up, because one of the things he was also complaining about as this kind of unraveled is that he felt he was starting to look down at the floor again. So, but yes, I think he is overcorrected.
No. And it'll kind of transition to this. Do you want to go into this one, or do you want to go back on this one?
So with the end point on him, I mean, he's an attorney. He's very active. He was a triathlete, yada yada
Wow.
before all this started. And he's actually doing quite well. He was at a point when we did the lower part, he couldn't walk. He was just losing the ability to walk. He was depressed. He had prostate cancer. He had some cardiac issues, and so he was dealing with quite a bit. So I think with his physical therapy, he's more upright, and in the kyphosis, and this is kind of one of the reasons I wanted to present this, but we have a program where we do put patients on the walking sticks. He was having issues with proprioception and balance. So what actually happened, the other x-ray, but his kyphosis in his thoracic spine actually lessened. So now he's probably about 8 months, I think, out from the thoracolumbar, and he's actually there. Him and his wife are going to England next week. I just talked to him yesterday. So, yes.
Like a sarcopenia, muscular, what would you pin this on if you could try to characterize what the hell happened?
Yeah, I think that was part of it, and I don't know, going back to the beginning, as far as the weakness in his legs and all, and yeah. Right. Yeah. I don't know.
He doesn't look very sarcopenic on the
Yeah.
axial. So some people just have bad discs.
Yeah. And he's a
They have
thin
bad
guy. I mean,
protoplasm and they just fall apart.
yeah.
You touch them and they fall apart.
Who would have actually not gone up to T10 and would have done? I think, Cliff, you were kind of.
I was debating it, but that's probably where I would have landed. I kind of got stuck right in the beginning, kind of go, geez, why this guy even have a back operation at all? You wonder if he never had the 4-to-1, if he would have evolved that way at all.